Hello, my dear future nursing officers. I welcome you all once again back to the Master Nursing classes, where the most complicated things made easy, and very easy for the students to understand better and give their best in the exams to get the better rank. So, dear aspirants, in the last very important session, we have covered the very beautiful content that is on the non-nursing. So I request every one of you to completely watch the yesterday's class also after this particular very important class. If you are still not completed that one, so please do complete that one. Okay. And the today's class is also having the very high yield and the very important questions. So questions which I am very frequently getting on my WhatsApp and in the Telegrams, Instagram continuously, sir. This is the doubt we have. So completely those questions which is there in our doubt box. So that is related to the TB and its updates and blindness control program, few very important updated guidelines and many more things that is necessary for the exam we are going to cover in this very important session, because this is one of the very high yield and this is one of the very important session. From here you may expect one question or two questions directly in your exam. So completely pay attention, and wherever I am telling this is important, so please do pay the special attention on that one. And the concept what I am explaining to you, so that is much necessary to you to remember, understand and give the best shot in the exam. So we are not only studying the questions, we are studying the concept, and concept is the thing which makes us a champion. A very good evening to one and all. So I welcome you all once again back to the Master Nursing classes. Namaste and good evening to one and all. Good evening, namaste. So welcome you all once again back to the Master Nursing classes. I hope audio, video, everything is very perfect, and I am going to start the session now without wasting a single minute of the time. Okay, so can we start the session now? Fatapat do thumbs. Can we start the session now? Yes, almost all. Every one of you have joined, so let's begin the session now. Okay, so here it comes to a beautiful motivational image and the quote that is explaining the only one thing, that is you can do it. Dear aspirants, you have to be very proud about you, because many people is not having the daring to start their preparation. So you have already started the preparation. That is the reason you have to be proud about you, and now you are at the end of your preparation, so that is the reason you have to be proud about you. So you are jumping from here to here. Already you have took a jump, just you have to land perfectly, so the thing is very much perfectly, so which is there here, that's the you can do it, it is possible from you. So never ever say whether it is will be happen or not. So you have to say I will do this one, I can do this one, so it is possible from me, and I will do this one very perfectly. So this should be our mindset, and that is only going to add a 2 to 3 extra positive marks, and that is only going to remove your 2 to 3 negative marks. So that is only going to decide your rank. So let's begin the session with this powerful motivational line. Always you have to say that I am possible and never say impossible. Okay, yes. So let's begin the session. Here it comes to the first question. What is the primary cause of the RH incompatibility during the pregnancy is the question. During the pregnancy, what is the primary cause of the RH incompatibility is the question. Option A, explaining about ABO blood group mismatch. So this is called as the ABO incompatibility, not RH incompatibility. So this is completely unrelated to this one, so eliminating the option A. Then comes to the option B. Option B is explaining about RH positive fetus and RH negative mother. So absolutely, if incompatibility want to happen, means the fetus which should be inside the womb of the mother should be RH positive, and the mother blood group should be RH negative. So then only the RH incompatibility will happen. So option C comes RH negative fetus and RH positive mother. No, if the mother is RH positive, so there is very less chance of the RH incompatibility. So please do remember the criteria. The fetus should be RH positive and mother should be RH negative. And option D, so that is the inherited clotting disorder is there. So there is no any clotting problem in this one. So option D also wrong. So the correct answer for this question goes to the option B. So I hope it is very much clear to everyone of you, right? So what happens here? Understand carefully. What is RH incompatibility? How it happens? Whether it will affect the first baby which is there in the womb of the mother, whether it will affect the second baby, to which baby it will actually affect, and what should be the a positive screening, what we can say, where we will give the RhoGAM injection to the mother irrespective of the RH sensitivity. So all the things that is necessary for the exam I am going to explain you here in a very perfect manner. So please do listen carefully. Consider this is an mother body. This is on the mother body. Okay. So here inside the mother body, you consider this one is the uterus. Okay. So just for the concept clarity purpose. Okay. So this is the red one is the entire mother body, and inside the mother body there is in the uterus. Inside the uterus we have the a growing baby, that is what you call as the fetus. Okay. So this is the a fetus you consider. Okay. Yes. So the criteria what I told, the mother should be RH negative. So mother antigen which is there here is the RH negative. It means there is no any antibodies there in the mother body. There is no antibody because her blood group is RH negative. And in her womb, there may be in the RH positive baby. Sir, how the mother will carry the mother is negative means baby also should be negative, na sir? How the in a negative mother positive like factor will come, sir? So that is from the parent, means that is from the father. Okay. So if the mother is RH negative and father is RH positive, so there is chance of the fetus may get RH positive. So fetus may get RH positive. Okay. Yes, sir. So now suppose during the time of the delivery, when this particular fetus which is there inside the uterus, while going out, due to the any reason, there may be in the entry of this particular RH positive into the mother circulation. So now RH positive blood group by mistakenly entered into the maternal circulation. Already mother is having the RH negative. Now by mistakenly from the fetus, RH positive group is entered to the mother. So what mother body will do now? So mother body will consider this one as the foreign body, and this is an the antigen which is came from the fetus. Against this particular antigen, the mother body will start to form the RH positive. So that is the antibody against this one. Okay. So mother body will start to form the antibody against this RH positive antigen. Okay. Now the fetus went out of the mother body, means nothing will happen to the first fetus. When the woman is first time pregnant, that time the RH incompatibility will not happen. So when she is first time pregnant, her blood group is RH negative and the husband is RH positive. So by mistakenly fetus is also coming as on the RH positive. So during the time of the delivery, this RH positive group factor may enter into the maternal circulation. So now mother body is forming the antibody against the RH positive. When this particular mother may get pregnant second time, so when she will get pregnant second time, during that time, if in case this particular fetus is having the RH positive blood group, now in the maternal body, there are the antibodies are there. These antibodies will enter into the fetus. So now there is the antigen antibody reaction which happens and which will cause the heavy damage of the RBCs. So that is called as the hemolysis. So that is happening due to the incompatibility between the RH a positive baby and the antibodies against the RH positive baby. So that is what we call as the RH incompatibility. RH incompatibility. Or we also say RH isoimmunization. Okay. So the most importantly, What happening here? The antibody is destroying all the RBCs. The hemolysis is happening. The hemolysis is happening. And because of this hemolysis, there is increase in the bilirubin. There is increased bilirubin. So this increased bilirubin in the neonate we call as the neonatal jaundice. And please do remember the most common cause of the neonatal jaundice is RH incompatibility. RH incompatibility, which will cause the heavy hemolysis. So because of the heavy hemolysis, there is an increased bilirubin level in the body of the newborn. So that is called as the neonatal jaundice. And the most common cause of the neonatal jaundice is the RH incompatibility. Now here inside the fetus body, there are the lots of the RBCs are got broken and the lysis is happening. The fluid which is there inside the cell, everything which will comes out, okay, and the entire body of the fetus will be filled with the fluid. So we call that one as the hydrops fetalis. What we can call that one? So this is called as the hydrops in the sense, the hydrops means in the sense the accumulation of the water. Where it is accumulating inside the fetus body, so that is called as the hydrops fetalis. Okay, yes sir. So RH incompatibility may leads to the hydrops fetalis. So please do remember, this is for your exam, right? Yes sir. Sir, we have heard about the injection RhoGAM. What is the purpose of the injection RhoGAM here, sir? So purpose of the injection RhoGAM, what I told. So when the fetus RH positive group is entering into the maternal circulation, so that time the mother body is forming the antibody against this RH positive antigen I told. So if we give the injection RhoGAM, there we can prevent the formation of this antibody. So there is no formation of this antibody, means this antibody will not go into the fetus, and there is no hemolysis. There is no hemolysis. So we can say there is no pathological jaundice. Okay, so that is in the newborn, and there is no RH incompatibility, we can say. So in order to prevent the RH incompatibility, we are giving the RhoGAM, not to treat. We are not treating the RH incompatibility by using the RhoGAM. We are preventing the RH incompatibility by giving the injection called as the RhoGAM, and the RhoGAM is the examiner favorite question, the multiple time asked question in the exam. We will discuss everything, what is the dose, everything that is necessary for our exam we will discuss. Okay, yes. So I hope it is very much clear to every one of you. So that is the one more time the basic concept. The father is positive here, and the father is positive here, RH positive father, and he went into the reproductive process with a woman who is RH negative, means the mother is RH negative here. So father is RH positive and mother is RH negative, means there may be a chance of the forming the fetus with a RH positive inside the mother of like inside the uterus. So during the delivery time, the baby when coming out, so that time this particular RH positive which is there inside the body of the fetus, that may enters into the maternal circulation. So now the baby went out. Okay, so here you can see in the next image there is no baby, because while delivering only this blood entered into the maternal circulation. So normally the placenta blood and the blood of the fetus and blood of the mother will not exchange each other. Okay, so that will not be exchanged each other. So that is the reason I am telling, when the chance is there, so during the delivery, due to any small cut or whatever the reason, okay, so from the umbilical cord, so the baby's blood may going into the maternal circulation. So in the maternal circulation you see the mother is negative, but the baby blood came here. So against that baby blood there is in the antibody formed here. Okay, so there is the antibody formed here. When the woman is second time pregnant, so woman is the still negative only, and the baby is positive again. So but now this time in the mother body there are the antibodies that is formed against this positive blood. So these antibodies will enter into the baby's body, so through the crossing the placenta, and that will do the hemolysis in the newborn, that will causes the RH incompatibility or the most importantly hydrops fetalis. So I hope it is very much clear, right? Yes sir. So this is the basic concept. Now you have to tell me, in RH incompatibility the father RH factor should be, what should be the RH factor of the father, negative or positive? So fatapat do comment, what is the RH factor of the father? Yes, a father RH factor should be RH positive. Okay, so what is the RH factor of the mother? So the RH factor of the mother should be RH negative. And what is the of fetus? So the fetus which is there inside the mother. So what is the RH factor of this one? So RH factor which is come from the father. So that is the RH positive fetus. So that is the reason I told the mother should be RH negative and the fetus should be RH positive. Okay, sir, RH positive antigen which is there in the fetus, that antigen is entering from the fetus to the mother. So when it will be get shifting? So RH positive antigen from the fetus to mother shifted during what time? During what time? So I told this one will shift during the time of the process of the a baby which coming out. So that is called as the delivery or the labor. Okay. So during the delivery process of the baby or during the labor process of the baby. Okay. So this is the time where the RH positive factor of the fetus may entering into the maternal circulation. Okay, so the next very important thing is, so is there anything happens to the first baby? What is the effect on the first baby? So nothing will happens to first baby. So please remember first baby is always safe. So nothing will happens to first baby. Okay, so next one is effect on the second baby. What is the effect on the second baby? Yes. What is the effect on the second baby? So beta, on the second baby, what happening? Incompatibility is happening. So which incompatibility? So that is the RH incompatibility happening. So this may lead to the hemolysis. So when there is an excessive cell will get break, so all the fluid will leak into the body of the fetus. So that will cause the hydrops fetalis. That will cause the hydrops fetalis. So that is fetus body is completely filled with the fluid. So this is what you can call as the hydrops fetalis. Okay. So is that clear to every one of you? Yes. The next question is this one. When is the RHO, that is the RHD immunoglobulin, or we can say the RhoGAM injection is typically administered during the pregnancy. So during the pregnancy time, when we are going to typically or best time to administer the RhoGAM injection or the RHOD immunoglobulin. So option A is only after the birth. Option B coming here is the at 12 week and again at the 30th weeks. And option C comes at 28 weeks and within 72 hours after the delivery. And option D comes here at 20 weeks and during the labor. So what is your answer? What is the ideal time of administration of the RhoGAM injection or the RHOD immunoglobulin? So fatapat do mention your answer. Option E. Is that correct? No. So the yes, every one of you have given the correct answer. That is first we have to give the RhoGAM injection at the 28 weeks during the pregnancy. If not given, so at least we have to give that one within 72 hours after the delivery. So this is going to be a correct answer. Okay, and every one of you have chosen this one very perfectly. So I'm very proud of you. So remember the dose, route, and the dose route in the ectopic pregnancy, molar pregnancy, abortions, and the dose less than 13 weeks. So what to choose? These are the very important questions frequently asked and in the Norcet mains also. Last year the question have been asked on that one. So I am going to clear your concept now. So please do listen carefully. Okay. So here it comes to the next question. You can see. So the very important concept. So that is how this particular RhoGAM injection is preventing the RH incompatibility is the question. So already we have discussed this one. When the fetus positive factor is entering into the RH negative woman's body, so that is in the mother body is forming the antibody against the RH positive factor. If you give the RhoGAM injection at the 28th week of the pregnancy, so that is going to prevent the formation of the antibody. There is no antibody formation, means when the second baby will be there in the uterus, so that time there is no any destruction to the second baby. Okay, so because the RHD or the RHOD or the RhoGAM injection which we are giving, that is preventing the formation of the antibody against the fetus. Okay, so that is the very important. So how to prevent the RH incompatibility? So that is we have to give the RHD or the RhoGAM injection so to the mother. So when to give? At the 28th week of the gestation we can give, or within 72 hours of the delivery we can give. Sir, what it will do, it will prevent the formation of the antibody. This is very important to be keep in our mind. Next is, what is the standard prophylactic dose of the RhoGAM which is given to the Rh negative mother with the Rh positive fetus? So fetus inside the womb of the mother is, that is the Rh positive fetus, and the mother is Rh negative. What is the standard prophylactic dose we have to give in this particular condition? So the RhoGAM injection which we are giving. So what is the standard prophylactic dose of this RhoGAM injection is the question. Option A, 100 international unit. Option B is the 50 microgram. Option C comes here is the 300 microgram, and option D comes here is the 600 microgram. So what is the correct answer? So the correct answer for this one. So again, one more time, every one of you are rocking. So very best, that is the 300 microgram is the dose. So if the dose examiner asking in the international unit means, so how much international unit we will give? That is 1500 international unit. Okay, so please do remember 300 microgram or the 1500 international unit is the dose of the RhoGAM in the Rh negative mother, so who is having the Rh positive fetus. This is very important and very, very important. Now my next question is, what is the route of administration of the RhoGAM injection? Option A is the subcutaneous, option B is the subcutaneous, option C is the subcutaneous, and option D is the intramuscular. What is your answer? Option A, B, C, all three are the subcutaneous, and option D is the intramuscular. Yes, remember only one thing. So that is the intramuscular is the route of administration. Don't run behind the subcutaneous here. Okay, so intramuscular is the route of administration of the RhoGAM. So please do remember. Okay, so the standard prophylactic dose I told 1500 international unit or the 300 microgram, and by intramuscular route. So this is the very important. Please do keep in our mind. And here it comes to the all the golden points that we must and should need to know about this one. In case of the ectopic pregnancy, in case of the abortion, and in case of the molar pregnancy, in all these three situations, there is highest chance and risk of the exposure to mother by the fetus blood. Because of the abortion, molar pregnancy, and ectopic pregnancy, so fetus blood may enter into the maternal circulation, highest probability is there. That is the reason, irrespective of the Rh incompatibility sensitivity to mother, we will give RhoGAM to all the mothers if the mother is underwent in the abortion, molar pregnancy, and ectopic pregnancy. So what is the dose of the RhoGAM we are giving here? So in case of the ectopic pregnancy, abortion, and molar pregnancy, 150 microgram injection RhoGAM we are giving. But the standard what I told 300 microgram. Okay, so how we are giving? Intramuscular we are giving. So to whom we are giving? So we are giving to all the mothers if the mother is Rh mother is negative and the father is positive, to those all mothers irrespective of the Rh incompatibility in the mother. If the mother is negative and the father is positive, so we will give a very important injection RhoGAM, that is 150 microgram intramuscular. If in case the pregnancy is terminated less than 13 weeks, so the dose of the RhoGAM goes to only 50 microgram. Okay, so for which one will be most frequently asked in the exam, sir? So this one is the most frequently asked in the exam. So please do remember, this is important for the exam. Okay, yes, sir. The next question is here. So we have the two very important tests, that is the indirect Coombs test and the direct Coombs test. So what is the difference between these two tests? So these are the tests which will detect the antibodies in the blood. So that is in the blood vessels we can say. So consider that is, this is the blood vessel. This is the blood vessel. Okay. And here we have RBC you consider. If any antibody which is directly coming, attaching and destroying this particular cell, if you are detecting this one, so this is called as in the direct Coombs test. So this is called as the direct Coombs test. What you can call this one? This is called as the direct Coombs test. No, you are not detecting the antibody which is direct attached with RBC. So you are just trying to detecting the antibodies which are freely floating in the plasma. So these antibodies you are trying to detect. This is called as the indirect Coombs test. This is called as the indirect Coombs test. What is this, sir? This is the indirect Coombs test. Then where to perform the direct Coombs test, sir? If there is in the hemolytic anemia in that particular situation, the direct Coombs test is the best test. If in case of the incompatibility, that is in the RH incompatibility, the indirect Coombs test is the best test. What indirect Coombs test is measuring? Indirect Coombs test is measuring the antibodies which is freely floating in the plasma and it is not attached with the surface of the RBC. The antibodies which is directly attached with the surface of the RBC, if you are checking this, that is the direct Coombs test. Okay, directly attached, direct Coombs test. Not attached, indirect Coombs test. Indirect Coombs test is done in the incompatibility, so please do remember, and the direct Coombs test is done in the hemolytic anemia. Okay, so this is the concept. Here we have the indirect Coombs test, so that is done in the incompatibility case. So please do remember, in is equal to in. Okay, indirect Coombs test we have done in the incompatibility situation. Next we have the direct Coombs test. This direct Coombs test is done in our hemolytic anemia. Okay, so that is in our hemolytic anemia situation. We are going to perform the direct Coombs test. Okay, so I hope it is clear to every one of you. Yes, here it comes to the next question. In HIV positive patient, what is the induration which is considered as the positive in the TST? Sir, what is the TST? TST we also call as the tuberculin skin test, the Montex test, or the Percute test. Montex test, tuberculin skin test, or the Percute test. So these are the three names of the test which we are performing to detect the exposure or the previous exposure of the patient to the TB. So by performing this test, we are not going to confirm the TB. We are not going to screen the TB perfectly. So this is the test. We want to know that patient whether previously exposed to the TB or not. If the patient exposed to the TB previously, so it may shows the positive. If he not exposed to the TB previously, it will shows the negative. Okay, so HIV positive patient is there. So in this particular patient, what is the size of the induration? What is the size of the induration which is considered as the positive tuberculin skin test is the question. Option A is the more than 5 mm, B comes the more than or equal to 10 mm, and C is the more than 15 mm. In all the normal individuals, okay, all the normal individuals without risk factor. So those individuals, if you want to say that there is in the positive Montex test in all the normal individual means, so you have to measure the induration that should be more than 15 mm. Okay, so in the high risk individuals like a hospital staff, lab workers, and the like children less than 5 years of the age group, in this particular situation, if you want to say the positive tuberculin skin test means that the induration should be more than 10 mm. But in the immunocompromised patient and in the HIV patient and the patient who is using the steroids and all, so in those patients, when we will say the positive tuberculin skin test, so that is we are going to describe when the most importantly this particular tuberculin skin test is considered to be a positive in a HIV patient when it will be measured more than or equal to 5 mm. So I hope it is very much clear to every one of you, right? Yes, sir. So yes. So the next very important rapid revision points we are going to keep in our mind. So when we are going to measure this induration, so the induration of the tuberculin skin test to be read after the 48 to 72 after hours injection. So this is very important. When you are going to measure the induration of the tuberculin skin test. So microbiologist have been came and he brought some purified protein derivative 5 tuberculin unit. So he administered that one intradermally here. Okay, so we have marked that particular area. So that is when the tuberculin skin test have been done. And after how many hours we are going to assess the induration? So induration to be assessed after 48 to 72 hours after the injection. Very important. And the next very important point to remember is this measures only the induration. So sorry, while measuring, you are going to measure only the induration, not the redness. Okay, so what it means, sir? Consider. So this is your palm. This is your palm. Okay, and this is the fingers and palm, and this one is the our ventral portion of the our forearm. Okay, so this is the dorsal portion of the forearm. This is the ventral portion of the forearm. So this front one is the ventral portion of the our forearm. And you know the ventral portion is the best site to check the any allergic test. So if you want to do the AST, that is the antibiotic sensitivity test, the AST antibiotic sensitivity test, the best site of the administering the antibiotic to check its allergic reaction. So that is a ventral portion of the forearm. And if you want to know the xylocaine sensitivity test, again where you are going to administer the xylocaine or the lignocaine, so that is we are going to administer again in the ventral portion of the forearm. And remember, dear students, here if you want to perform the tuberculin skin test, also the best site of administering the purified protein derivative is the PPD is you are going to administer in the ventral portion of the forearm. This is the previously asked question. Okay, sir, we understood. So I have taken the tuberculin syringe and I have loaded the 5 tuberculin unit of the purified protein derivative. 5 tuberculin unit is equal to 0.1 ml. Then I have checked for the any damages, any infections, any sutures over the this particular surface. So that is over the ventral aspect of the our forearm. Here there is nothing is there, so I administer the purified protein derivative. My question is, by which route you will administer? Option A is intradermal, option B is intradermal, option C is both A and B, and option D is nothing. So you just answer. So the route of administration of the purified protein derivative is intradermal. So please do remember. And in the option, first option only, examiner will give the subcutaneous. Don't choose the subcutaneous as an answer. Every allergic test to be given by the intradermal route. Please do keep in your mind. Okay? Yes, sir. So now I given the a very important intradermal injection here. So after the 48 to 72 hours, I am going to assess this particular site. Okay, sir, what you are going to assess in this particular site? Here I have given you consider. So this much area which is there here. So this becomes hard area and this becomes tight area. This becomes area which we can say it is looking like an inflamed, and so this is called as the induration. And around surround of this one, so there is in the redness is there. Around surround of this one, there is in the redness is there. What we are going to measure? We are going to measure redness or the only induration. So beta, here we are going to measure only induration. Okay, so that is we are going to measure only induration, not the redness. The very important point to be keep in our mind. Okay, yes. So here are the interpretation. So that is we must and should keep in our mind. That is more than 5 mm is coming. The induration size is more than 5 mm. That is considered positive in a HIV positive individuals, and the individuals who went to a country, the individuals who are recently like in a direct closed contact with the active TB infections. Okay, so in the HIV positive individuals, recent closed contact with the TB cases, and the individuals who have been done with the organ transplantation. And after every organ transplantation, you know that we will give the immunosuppressant therapy because our body will reject the organ. So in order to prevent the rejection, we will give the immunocompression therapy. So if any patient who is on the immunocompression therapy, especially steroids and the chemotherapy, so these patients' immunity is very low. So reaction towards our purified protein derivative is also low. So that is the reason in those patients, if the induration is coming more than 5 mm, so that is I am going to consider as the positive. Okay, so next one is, so this is, if the induration is more than or equal to 10 mm, this is I am going to consider positive to a nursing officers, to a lab technicians, and to all the lab workers who is working in the microbiology lab, and the children less than 5 years of the age group. Okay, and those peoples who came recently from a country where the TB burden is more. So those countries. So that is the candidates who recently immigrants from the TB burden countries and the IV drug abusers, not users. So this is in the IV drug abusers. Okay, abusers and the healthcare workers like a nursing officers, doctors, and the lab workers, because we have already exposed to the TB. Okay, so the children that is less than 5 year of the less than 5 years with a risk factors like diabetes, CKD, and the cancer. So these children we are going to consider as the a positive in this particular situation. So please do keep in our mind, directly, indirectly, every healthcare worker, even me, you, everyone is exposed to the tuberculosis. We are not suffering with the TB because our immunity is good. So even when you become a nursing officer, so it keeps on telling one word to you all: don't go to the hospital clinical work without having a sufficient breakfast and the good health and the good immunity. If you are going to hospital settings, around surround of you completely full of infection, and in middle that is you are immunocompromised patient, immunocompromised nursing officer, so you will get the infection. Okay, so there are very less medical leave you have, so don't like don't take any medical leave in your full of the service, because your health is directly dependent on the how you will be maintaining that one after becoming a nursing officer. Okay, so please do remember, right? So this one is the most important, right? The next one is, so for all the healthy individuals with no known case of the TB risk factors. Okay, so healthy individuals are there, so there is no any risk factors. So to those peoples we will consider positive when the induration size will be more than 15 mm. So that is considered positive in a healthy individuals with a no any known case of the TB and risk factors. Okay, so now leave this one. So don't look at the screen, so just look at me and show your very important put your very important answer in the comment box. Okay, so try to put your correct answer in the comment box. So the question is, a 4-year child is there with a CKD, that is the chronic kidney disease. In that particular child, how you are going to interpret the tuberculin skin test is positive? So option A, you are checking the induration size, that is more than 5 mm but less than 10 mm, and option B is the induration size is more than 10 mm but less than 15 mm, and you are making that is consider that is negative because it is not 15 mm. So what is your answer? Your answer should be yes, more than 5, like less than 5-year child. So that is the 4-year child I told with a CKD. In this particular child, if the induration is coming off around the 10 mm or more, so that is considered as the positive. Okay, so please do keep in your mind. That is important for the exam. Okay, yes sir. The next very important thing to be keep in our mind is this very important golden point. So that is the points about the Montex test, tuberculin skin test, or the percute test. So these tests are all a test of the one, like name of the one test. Okay, we will call the Montex test the same thing, the tuberculin skin test, and the same thing, the percute test. All means same. Percute test is the very old name, so that is converted into the tuberculin skin test and the Montex test. Okay, so if examiner is asking a question about all these three, remember these all three are the just a different name of the one test. Okay, yes. So already all the points are discussed once. Just I am going to revise very quickly. This particular tuberculin skin test is going to detect the which type of the hypersensitivity reaction, that is going to detect the delayed type of the hypersensitivity reaction to the Mycobacterium tuberculosis. Okay, and here we have the PPD. So what we are going to administer subcutaneously, that is the purified protein derivative is the thing which we are going to administer by the not subcutaneously, but that is by the intradermally. Okay, so that is injected by the intradermally. Okay, please do keep in our mind, sir, where we are going to administer this one. So this is in the forearm. So which part of the forearm? So please do remember the ventral portion of the forearm. Okay, so this is in the ventral part of forearm. Okay, and what is the standard dose? There is the 5 tuberculin units, or the we can say 0.1 ml also. Okay, so 5 tuberculin units are the 0.1 ml you are going to administer. So when we are going to measure the test, already discussed one, that is 48 to 72 hours after the injection you are going to measure the test. Okay, so next is only induration is measured, not the redness. I have told already this concept. And BCG vaccine may show the false positive result. Okay, if the like person is heavy immunocompromised, so in the heavy immunocompromised patient, so that like HIV patients and the patients on the steroids, so this may show the false negative tuberculin skin test. So please do consider this one as the extraneous variables. Okay, so next we have that is the tuberculin skin test is done not to differentiate between the latent TB and acute TB. So I told this is not to differentiate, this is not to diagnose, this is just explains whether the person is previously exposed to the TB or not exposed to the TB. Coming positive means the person is previously exposed to the Mycobacterium tuberculosis. If it is coming negative, the person is not exposed to the tubercular bacteria. So that is the very simple thing to be keep in our mind. Okay, yes sir. The next very important question is this one. Yes, WHO now recommends which duration of the treatment for the drug sensitive pulmonary TB in eligible adults. So in eligible adults, now the World Health Organization is recommending which duration of the drug sensitivity pulmonary TB. Dear aspirants, so here many of you have the confusions are whether we have to follow the WHO guidelines or the National Tuberculosis Elimination Program guidelines. So my clear answer for you all is listen carefully. In the exam, examiner is clearly mentioned that what is the answer according to the WHO new guidelines? What is the answer as per the latest guidelines? Then you go for the WHO updated guidelines. If we nothing mentioned, go for the National Tuberculosis Elimination Program guidelines. Both I will teach now, and I will train you in a very perfect direction, and I will show the way how you have to go here. So that is very much clear to every one of you at the end of this concept. Okay, listen carefully. So the question is now in the question they mentioned WHO now recommends, now in the sense that is a recent one, so that is the updated one, which duration of the drug sensitivity pulmonary TB in the eligible adults. So now WHO given a new regimen, so that is the 4-month regimen. In this particular 4 month, the 2 months are the intensive phase and the 2 months are the continuous phase. Okay, so everything about the new updates which is there in the drug sensitive TB, which is given by the WHO, so that we will study now. This is not a National Tuberculosis Elimination Program guidelines. This is in the WHO guidelines. This may be expected, like accepted by the NTEP in the future. Still now, still the date, the National Tuberculosis Elimination Program not adopted this very important WHO guidelines. So if any updates are there in the future, so I'm going to give on the time. Don't have to worry. Okay. So still the date I have waited whether our NTEP guidelines are going to accept this one or not. So still the date they have not accepted this one. Okay, so WHO updates are there, but in the NTEP program there is no any change. So the 6 month what you have studied, the 2 month for the intensive phase and the 4 month for the continuous phase in the National Tuberculosis Elimination Program. So that is only going to follow in the next Norcet. Unless if the examiner is clearly asking what is the new WHO guidelines, then you give the answer according to this guidelines. If not mentioned, give the answer according to our old guidelines. So that is by the National Tuberculosis Elimination Program. So now we will study what are the change which the WHO, like the World Health Organization updated. So major change which is given here is, so traditionally in the NTEP, so not traditional, so we can say that is in the National Tuberculosis Elimination Program. Previously, this NTEP we also call as in the RNTCP, that is the revised National Tuberculosis Elimination Program. So that is the RNTCP. So that is control program. So now we have the NTEP. So that is the National Tuberculosis Elimination Program. So according to this one, we have the 6 month duration. That is the 2 month HRJD and the 4 month HRE. So that is 4 month which we have is the HRE. So that is, we don't have the we don't have the pyrazinamide in the continuous phase. So this is a traditional, what you can say, are the our national tuberculosis elimination program. So according to that one, so this is the correct answer. So now WHO is telling that shorter 4-month duration. So that what is the main purpose of the shorter 4-month duration? Because this one want to improve the adherence with the treatment. As all of you know that how much important to be adhered with the treatment. So that is, patient is taking the 10 to 20 days of the tablets and he is forgetting and he is not taking the tablets, means his simple tuberculosis, the drug sensitivity tuberculosis may get converted into the drug resistance TB. So treating of the drug resistance TB is very difficult. Sometimes patient responds and sometimes patient going to die. So that is the reason the adherence with the medication is very important in the a patient who is taking the anti-tubercular therapy. So for the promotion of the adherence, the government have initiated lots of the programs. Okay, so many more things. So that is, we have already discussed in the national health programs. Okay, so very importantly, remember the shortening of the duration of the treatment. Main purpose is to promote the adherence with the treatment. Okay, so next is reduces the treatment duration. So that is, previously the 6 months which we are giving in the NTEP, the WHO says to give 4 months and maintains the high cure rate. Is the, these are the aims which is given in the 4-month regimen of the WHO. Okay, sir, for like new 4-month regimen, what are the things which is including, sir? So this regimen is including the 2 months of the intensive phase and the 2 months of the continuous phase. So the 2 months of the intensive phase, what are the things we are giving, sir? We are giving the isoniazid. H stands here as the isoniazid, and remember P is not rifampicin. So this is the rifampicin, not rifampicin. So this is the rifampicin. Previously, so the rifampicin we are using in the NTEP. So in the new WHO guidelines, that is the rifampicin we are using. And the Z stands here is the pyrazinamide. Okay, so Z stands here is the pyrazinamide and the M stands here is the moxifloxacin. Sir, which first line drug which is not there in the list, sir? So that is the ethambutol is not there. So ethambutol is replaced by the moxifloxacin. Rifampicin is replaced by the rifampicin. So please do remember. Okay, rifampicin is replaced by the rifampicin and the moxifloxacin, which comes here in a replacement of the ethambutol. Okay, so ethambutol exit. Okay, so he is going to exit. Okay, which is going to out, and the moxi is going to come in. So please do remember. Okay, so next in the continuous phase of the 2 months, we are giving the again the isoniazid, pyrazinamide and moxifloxacin. So this is for the drug sensitive tuberculosis. Okay, and golden point about this one, the rifampicin replaces the rifampicin. So rifampicin is not a part of the like treatment of the TB. Now it is said by the WHO. So this one is replaced by the rifampicin. So why rifampicin? As compared to the rifampicin is having the longer duration of the action. Okay, so this is having the longer duration of the action. Longer duration of the action. So that is the reason the rifampicin is primarily involved here. Okay, so next which we have is the moxifloxacin, which is added new. Okay, and we have the ethambutol removed in the new WHO regimen, but the ethambutol is still there in the NTEP regimen. Okay, so the moxifloxacin which is there here, which is added, and the ethambutol is removed. So please do remember. Okay, yes, sir. And this is recommended to which cases? The cases must and should be sensitive to the treatment, that is the drug sensitive pulmonary TB only, and adults and adolescents which is more than 12 years of the age group, and the selected patients with non-complicated, like there is no any complicated with the TB. So those selected patients we can take. Mainly and mostly the primary criteria should be the patient should not be resistant to the drug. So that should be a drug resistance TB, and so that should be a drug sensitive TB. And the next very important is more than 12 years of the age group. So that is in the adults and adolescents it is recommended. Okay, but we have the one more very important thing to be remembered, that is our national tuberculosis elimination program. So in the question, examiner is asking new WHO guidelines, give the answer till that what I have given, and in the like in the question exam there is mentioned as per the latest guidelines, give the WHO guidelines in an answer. Nothing is asked about the latest WHO recent guidelines. Nothing is mentioned in the question. So do follow the NTEP guidelines, and this is a like the new WHO guidelines are still not replaced this everything. Still India following this one, and that is still not adopted by the India. So please do remember. Okay. Yes, sir. In the NTEP program, so that is the National Tuberculosis Elimination Program. So this program is having the treatment like intensive phase of the 2 months. In this one, we are going to provide the isoniazid, rifampicin, pyrazinamide, and ethambutol. Alright? Is that clear? Yes, sir. So can I ask some question to every one of you? The very high yield questions. So there is on the 14-year child is there. So where we have started tuberculosis treatment. So that is the anti-tubercular therapy have been started. Now that particular mother is coming with that particular 14-year child to the hospital, and she is complaining that the patient is getting the orange color urine. So what is the reason behind this one is the question. Yes, among the all these 4 drug, which drug is responsible for the orange color urine? Yes, remember that's the rifampicin is responsible for the orange color urine. So if the patient is having the peripheral neuropathy, among these 4, which drug is responsible, and for why we have to give the vitamin B6 to a patient who is taking the anti-tubercular therapy? Why? Because we have the drug that is called as in the isoniazid. So this isoniazid, that is the H. This isoniazid or the H. So this is going to be a anti-tubercular. This is a very important anti-tubercular drug, where it is going to cause the peripheral neuropathy, where the patient will complain you regarding the tingling and the pricking sensation over the periphery. Okay. Yes, sir. The next very important thing is, because of the anti-tubercular therapy, patient is unable to hear the thing which is explained by someone else. So which drug side effect is that one? Yes, that is aid cranial nerve damage by the streptomycin. Okay, so streptomycin, only injectable intra like tubercular therapy we have. So that is the streptomycin, right? Is that clear? Yes, sir. So now patient is having the difficulty in the vision. So there is the change in the vision. Okay, so what is the reason behind that one? Which drug is responsible for the visual changes? Yes, so don't focus. So some don't focus on the technical issues. So some technical issues there. So just focus on the question what I'm asking. Okay, so please keep on continuing your answer. So in the anti-tubercular therapy patient, so patient is complaining about the visual changes. So which drug is responsible for that one? Option which is there again in front of you. So that's the isoniazid, rifampicin, pyrazinamide, and the ethambutol. Yes, due to the ethambutol, there is an change in the vision. So please do remember. Okay, so these are the very important thing to be keep in our mind. Okay, so next which we have is the continuous phase of the our anti-tubercular therapy NTEP program. Okay, so this one will be for the month of, this is for the duration of the 4 months. Okay, in this one we are not giving the pyrazinamide, we are giving only drug, that is the isoniazid, rifampicin, and the ethambutol. So pyrazinamide will be not a part of the continuation phase. Okay, so it is not a part of the continuation phase. Which one, sir? That is the pyrazinamide. Okay, so please do remember, these are the important thing. From here you may expect a question directly in your exam. Okay, yes, sir. The next very important thing is this one, the total duration of the our national tuberculosis elimination program. Total duration, that is for the 6 months. Okay, so 2 months will be HRJD and 4 months will be HRE. So that is the isoniazid, rifampicin, and pyrazinamide, ethambutol. And here is the isoniazid, rifampicin, ethambutol. There is no pyrazinamide. There is no pyrazinamide in the continuation phase. Next, which we have is the daily therapy. So this is not intermittent, and compliance with the medication is very important. Patient should take the medication continuously until the completion of the 6 months. If he is like not taking the medication in middle means, so the drug sensitive TB may get converted into the drug resistance TB. So that may be a rifampicin resistance TB, or that may be on the a multi-drug resistance TB or whatever it may be. Okay, so it should be a daily therapy and patient should take this one daily. Okay, so this is given as a fixed combination dose, means we will not give the isoniazid, rifampicin, paracetamol separate. So there is in the one tablet. In that one tablet, all the composition will be there. Okay, so we are providing the fixed combination dose. So this is very important to keep in our mind. Okay, so this is based this particular dose is based on the age band. Okay, so this is based on the weight band. So that is very important. You are going to keep in our mind. Okay, so this particular dose is going to decided based on the weight of the person who is suffering with the TB. So this is the National Tuberculosis Elimination Program guidance. So this one we have to keep in our mind. This is important for the exam. Okay, so I hope it is very much clear. So now you have to tell me, you are in your exam, in your question, so these words are mentioned. So what should be your answer? Okay, so in the question, WHO recent guidelines is mentioned. Okay, otherwise only recent guidelines is mentioned. Otherwise 4-month regimen is mentioned. 4-month regimen is mentioned. Otherwise the short course regimen is mentioned. Short course regimen is mentioned. So what you are going to follow? So if these words are there in your question, so you are going to follow WHO recent guidelines. You are going to follow WHO recent guidelines. That is the 4-month guidelines. 2-month intensive phase, 2-month continuous phase, and rifampicin is not there. Instead of that one, rifapentine is there, and ethambutol is not there. So instead of that one, the moxifloxacin is there. Okay, so there is nothing is mentioned. So in the question they have mentioned national guidelines or the National TB Control or the Elimination Program, NTEP, or RNTCP. So these words are mentioned, means you are going to follow the Indian guidelines, that is the 6-month regimen. Okay, so you are going to follow this particular 6-month regime. So this particular 6-month regime, in this one, the 2-month which we have is for the intensive phase and the 4-month is for the continuous phase. Okay, so 2-month is for the intensive phase. Okay, so this is the intensive phase. Okay, so this is, in this one we are using the HRJD. In this one we are using the HRJD, and the 4-month which we have, so this is for the continuous phase. So this is for continuous phase. So here we have the very important, that is the HRE. Okay, so there is no Z. Okay, so there is no Z. So please do remember, these are the important thing to be keep in our mind. Okay, so next which we have is this question, that is the WHO recommended guidelines, which is we adopted already, that is the BPaLM regimen. So this one is also in the WHO guidelines for the drug resistance TB. So this is not for the drug sensitive TB. The BPaLM is for the this particular BPaLM regimen which we have. So this is for the drug resistance TB. So this one we have already adopted. So Indian government is adopted this BPaLM. Okay, so this is very important, we are going to keep in our mind. Okay, which of the following is true about the BPaLM regimen? So option A is that which contains the injectable drugs. No, BPaLM, all the drugs which is there in the BPaLM, that is the bedaquiline, betosemide, linezolid, moxifloxacin. All the drugs which we are giving in the BPaLM is the oral drug. So it is not in the injectable drugs. So the question is about the which of the following is true. So option A is not true, it is wrong. Option B comes to the duration is 12 months. But this particular BPaLM regimen duration for the drug resistance TB is not for the 12 months. Remember, this is only for the 6 months to 9 months. So single best answer is 6 months. Okay, yes sir. The next one is which includes the fluoroquinolones. Yes, which includes the fluoroquinolones. Which fluoroquinolones there, sir? That is the moxifloxacin. Moxifloxacin is the fluoroquinolone which is there in the our BPaLM regimen. So the used in the latent TB? No. So this is not used in the latent TB, drug sensitive TB, active TB. So this is used for the drug resistance TB. So this BPaLM regimen is used for the drug resistance TB. This is used for the drug resistance TB. So please do remember. Okay, yes, sir. So now we will study some very important golden points about the drug resistance TB. So that is very important for the exam. So we have the BPaLM regimen. So this is the first line for the multi-drug resistance TB or the rifampicin resistance tuberculosis. Okay, and in this one the duration will be the 6-month duration will be there. Okay, so 6 to 9 months, and the single best answer is the 6 month. All the medication are there. Here is the oral medications. There is no injectable medications. And moxifloxacin is the fluoroquinolone category. Okay, so yes, the next very important thing, the BPaLM which is there means this is the short course, not for the 12 months, and also this is only for the 6 months. All oral regimen is there. So I told already this one for the multi-drug resistance TB or the rifampicin resistance TB. The full form of the BPaLM is the B is the bedaquiline, the drug of choice among all. If the examiner is asking the which one is the drug of choice, so previously drug of choice, old guidelines says the drug of choice for the resistance, that is the multi-drug resistance TB, will be the moxiflox. So now moxiflox is the not a drug of choice. Now we have the drug of choice for the our MDR TB or the rifampicin resistance TB is the bedaquiline. Okay, so this is the bedaquiline, right? So next which we have the P stands or the PA, that is the pretonamide, and the L stands is the linezolid. Okay, so this is very important, and the question will strikes from here, which two drugs, which very important two drugs which is there in this particular line is responsible for the QT prolongation. So please do remember the bedaquiline and moxifloxacin, these both drugs will cause the QT prolongation in the UCC. So before starting this one, we have to take the cardiac fitness from the cardiologist. Okay, and the next very important, among these four drugs which is responsible for the neuropathy or the peripheral neuritis, so that is linezolid is going to cause the neuropathy or the peripheral neuritis. So this is a very important thing we are going to monitor here. Okay, yes sir. The next very important thing is this one. So QT prolongation, so bedaquiline and moxifloxacin both will do. If both is there in the option, sir, which one we are going to choose? The first priority give to the bedaquiline. Okay, so this will cause the maximum and this is the minimum. Okay, so the next very important is neuropathy risk will be there in the linezolid. Okay, so linezolid, where the patient is taking the linezolid or the linezolid weight we can say, so this one is having the neuropathy. So I hope it is clear to every one of you. Yes, so next is this one. Which of the following is correct about the Cyanopress? About the Cyanopress, which of the following is correct? Option A is that it is an intramuscular injection given monthly. So first you tell me what is the Cyanopress. Cyanopress is an alternative medication, so that we are using in the LARC therapy, so that is in the long-acting reversible contraceptive. This is also in the injectable progesterone. Okay, so that is the Cyanopress. Okay, yes sir. So in the injectable progesterone, which we have one more, that is the Antara. DMPA, that is the depot-medroxyprogesterone acetate, is the chemical which is there in the Cyanopress also and in the Antara also. Okay, so previously which is there in our national family welfare program, so that is the DMPA, that is the Antara we have. So now also we have the DMPA Antara and one more alternative which is there, so that is the Cyanopress also. Sir, what is the difference between the Cyanopress and the Antara? Very simple. So the Cyanopress and Antara is both having the DMPA only. Inside the both there is on the depot-medroxyprogesterone acetate only is going to present. There is no change, but the dose change is there. So the Cyanopress dose is only 104 microgram, and this Cyanopress I am going to give by the subcutaneous route. If the patient is coming to the hospital where the healthcare provider is not there, still the patient can take on his own. Okay, understand? If in the absence of the healthcare provider also, the Cyanopress can be taken by patient himself or the patient herself. Okay, so Cyanopress is very important. This can be self-administrable, and the antara which we have, that one is not self-administrable. Okay, so dose of the antara is 150 microgram that we are giving by the intramuscular route. Okay, yes sir. So this is very important. Now you tell me the correct statement about the Cyanopress. Option A is that it is an intramuscular injection given monthly, so it is wrong. It is first of all not in the intramuscular. Cyanopress is in the subcutaneous injection, and we are not giving monthly, so we are giving this one by every 3 months. Okay, so every 3 months one time we are giving this particular Cyanopress. Okay, so next option B, it contains the enough estrogen and progesterone. No beta, this is only an progesterone injection. This is not containing the estrogen. Okay, so I am eliminating the option B also. Then option C, it is on the subcutaneous injection given every 3 months one. So this is the perfect answer. It is on the subcutaneous injectable, so this is given once in every 3 months. Okay, and option D comes here. It prevents the pregnancy only by thickening the cervical mucosa. No, this is having the various rules. I will tell you. So this is the progesterone. This progesterone is going to send the negative feedback to the GnRH, and there is negative feedback to the our FHH also, sorry, to the LH also. So there is negative feedback to the LH, means there is no ovulation. So this will also prevent the ovulation. In the question they are mentioning it prevents the progesterone, but it prevents the pregnancy only by thickening of the cervical mucosa. No, this will also prevent the pregnancy by preventing the or inhibiting the ovulation. So that is option D also goes to the wrong option. Okay, so yes, the next very important thing, you can see the Cyanopress, that is the subcutaneous DMPA, what we can say, the depot medroxyprogesterone acetate, which we are giving by the subcutaneous route. This is given once in every 3 months, and progesterone only contraceptive. There is no estrogen is there in this one. Okay, mechanism of this one, this will do the thickening of the cervical mucosa, and this will make the endometrium very thin, and this will inhibit the ovulation. And the main thing is it will inhibit the ovulation. Okay, very important. The next very important thing is the difference between the antara and the Cyanopress. Already I have told the both will be given once in every 3 months. Both will be having the DMPA, that is the depot medroxyprogesterone acetate. But the difference is this very important. Cyanopress is we are giving lower dose, that is the 104 mg, sorry, not a microgram. So please do correct here. So this is milligram. Okay, so this is the mg. Okay, yes, right. So here the dose of the Cyanopress is lower dose 104 mg, and the dose of the our antara is 150 mg. Remember, and both are the long acting reversible contraceptives. And the antara we are giving by IM route, and the Cyanopress we are giving by subcutaneous route. Only this much is the difference. And the main important difference is the antara, if you want to give, whether patient should and must comes to the hospital, or the any peripheral health workers like ANM and all may go to the peripheral units. So that is patient should not administer themselves. So healthcare workers only given, that is the antara. But the Cyanopress is the preloaded syringe. So that is no need to load and all. So that will come in a preloaded syringe. This is the self-administration. This is the self-administrable. Okay, so this is very important. Right? The next very important thing is this one. According to the World Health Organization and the National Blindness Control Program, previously what happened? There is a controversy between the guidelines of the WHO and NBCP. Now the National Blindness Control Program, which is following the WHO guidelines only, and which is clearly mentioned in their a PDF of the NBCP, that is there in the national guidelines, like in the national website only it is there. You can go and check also there. Okay, so according to World Health Organization and the National Blindness Control Program, so the blindness is defined as, so when we can say as the patient is blind, visual acuity is less than 16 out of 80, And option B, visual acuity is less than 6 out of 60. This is old NBCP guidelines. This is old National Blindness Control Program guidelines. So now NBCP also tells the 3 out of 60 and WHO also tells the 3 out of 60. So this is one of the potential question which may strikes in your exam. So correct answer for this one, and as for the latest new guidelines, so correct answer for this one is that is visual acuity 3 out of 60 in a better eyes after the better possible correction. Remember, this is very important. And this 6 out of 60 is the old guidelines. This was the controversy. It was there between the WHO and National Blindness Control Program guidelines. Now the National Blindness Control Program guidelines also following the WHO guidelines, and they have removed this old criteria and they have now the new criteria, that is the visual acuity less than 3 out of 3, less than or equal to 3 out of the 60. So means a normal person is seeing the object from the 60-meter distance, where a person with a visual impairment is unable to see that one, that is from the 3-meter distance also. So that is less than or equal to 3 out of the 60 in a very better and after better possible surgery and correction. So this is called as a blindness. Okay, so as per the now latest guidelines of the WHO and National Blindness Control Program, the criteria of the blindness is this one. Remember. Okay, so previously NBCP used to say visual field should be less than or equal to 20 degrees Celsius. Now both guidelines says the visual field, it should be less than or equal to 10 degree. So then only we'll say the blind. Okay, and sir, patient is unable to read the things, then what we have to say? So we can see patient is unable to read the any or unable to see the any object from the 3-meter distance. So that is what we can say as on the legally blind. Okay, so that is very important. Visual field should be less than or equal to 10. Visual acuity should be less than or equal to 3 out of 60, and peripheral vision, so that is visual field what I told, so this is less than or equal to 10 degree. So this is called as the blindness. Okay, so this is as for the new NBCP guidelines and the old WHO guidelines. Now only one is there, so that's the option C. Okay, this is very recently updated, so please do keep in mind. Okay, yes, then here is the direct screenshot I brought from the National Blindness and Visual Impairment Survey, which is recently submitted, and this is taken into the consideration by our National Blindness Control Program. Okay, so the definition of the blindness and visual impairment you can see here. So here two definition only you are going to remember. One is, sir, the blindness definition. Another one is the severe visual impairment definition. Okay, yes, sir. So now blindness definition is, that is the visual acuity is less than 3 out of 60 in a better eye with available correction. So better possible correction like the lens you given, perspective given, surgery you done. After all these things also, the visual acuity is less than 3 out of 60 in a better eye. So that is called as the blind person. And if the visual acuity is less than 6 out of 60 up to the 3 out of 60 in a better eye with available correction, this is called as the severe visual impairment. Any question which may strikes in your exam out of these two, it may strikes from the severe visual impairment or from the blindness. Less than or equal to the 3 out of 60 is the blind, and less than 6 up to the 3, so that is the less than 6 out of 60 up to the 3 out of 60, so that is the severe visual impairment. So this is a very important thing to be keep in our mind. Okay, so next is, so these are all definitions. So if you want, you can, like you are a BS nursing student, if you want for your theory purpose, you can take all these things. So otherwise, no need. Okay. Yes. So if you are preparing for the Norcet, what I told the two definition, that is going to be a very helpful for you all. Okay. So next is this. Yes. Which of the following is on the secondary prevention strategy? So given all the very important options, so which of the following is the secondary prevention strategy? Not a primary, not a primordial, not a tertiary. So the question is about the secondary prevention. Yes, option A is telling that the pap smear for the cervical cancer screening. B is telling that the counseling of the stroke patient, and C is telling about the vaccination programs, and D tells about the use of the seat belts in a vehicle. So what is the answer? Which of the following is the secondary prevention strategy? So we have the levels of the prevention. That is the primordial level is the first. After that, secondary level, primary we have, after that secondary and tertiary. So total 4 levels of the prevention. Okay, yes. So we have the advanced level also, that is still not considered. So this much you already read, that is better. Okay, so primordial, primary, secondary, and tertiary. Okay, which of the following is the secondary prevention strategy is the question. So here we have the level of the prevention. You can see first one is the primordial prevention. So what is the meaning of the primordial prevention? Here we are doing the individual education to the high risk peoples and the mass education we are providing. Okay, yes sir. Then what is the main purpose of the primordial prevention? That is, we are reducing the risk factors. Sir, give some examples. Consider. So we are making some policies to reduce the risk factor. For example, this is the college you consider. This is the any college, okay, where the adults and young age people will go for their education purpose. So in the college life, you know, all the hormonal activities will be very high, and mind will be in a very fantasy. So if you see the alcohol shop daily in front of your college, so there is high probability in future you will get drink and you will get addicted to the alcohol. Okay, so there are the policy we made. Okay, so those policy which says surround of the school and colleges, you should not sell the any alcohols and the drugs. So that is surround of the college and school, we have reduced the risk factor. The reduction of the risk factor is called as the primordial prevention. I hope it is very much clear. Okay, yes sir. So the primordial prevention including the reduction of the risk factors. Next which we have is the primary prevention. Sir, primary prevention including what, sir? It is including the health education, health promotion and the specific protection. Okay, so what is the main purpose of this particular primary prevention? In this primary prevention, we are taking the action, so that is before the onset of the disease. Okay, so risk factors are present here. These risk factors may cause the disease. So here we are taking the interventions that before the onset of this disease only we are taking the like interventions. For example, we are giving the vaccine. We are giving the prophylactic antibiotic. Okay, so for example, we are doing some surgery. Consider. Okay, so in the surgery, the risk of the postpartum, post-operatively the surgical site infection may happen. So in order to prevent that one, the prophylactic antibiotic I am giving. So in the high burden state and countries and areas, there is in the risk of the infection. So where vaccine I am giving. It means specifically I am protecting, and I am taking this intervention before the onset of the disease in order to prevent the disease. So this is called as the primary prevention. Primary prevention means any interventions you are taking before the onset of the disease, that is the primary prevention. In this one we have the specific protection and the health promotion. Okay, so next which we have is the secondary prevention. In the secondary prevention, early diagnosis we are doing and the proper treatment we are doing. So early diagnosis in the sense, for example, breast self-examination we are recommending for the woman to early detect the breast cancer, and the pap smear test we are recommending to the woman to early diagnose the cervical cancer. So that is early diagnosis screening test we are doing. So that is the secondary prevention. So this one is reducing the complication and the progress of the disease. Here we are halting the progress of the disease. So already disease happened. So that disease may progress into complication before the onset of the complication. So we are reducing the complication and we are halting the progress of the disease. So that is called as the secondary prevention by the early diagnosis and the proper treatment. Okay. So in the question is asked, about the secondary prevention. So here, counseling a stroke patient, already stroke is happened, means here we are doing the rehabilitation. So that is the part of the tertiary level of the prevention. So this is on the tertiary level of the prevention. And vaccination program, so this is on the specific protection, and here we are taking the interventions before the onset of the disease. That is the primary level of the prevention. And use of the seat belts for the vehicles, again specific protection, primary level of the prevention. So here the early screening, that is the early diagnosis and the prompt treatment, is the secondary level of prevention. The pap smear test we are doing for the screening of the cervical cancer, so this is on the secondary level of the prevention, important for the exam. Okay, yes sir. So that is, we have the tertiary level of the prevention, that is disability limitation and the rehabilitation we are doing for the improving the quality of the life of the patient. So that is the tertiary level of the prevention, so please do keep in our mind. Okay, yes sir. So now I am going to ask some question to every one of you, so you have to tell me the answer to the question. So okay, don't focus on the screen, so just listen to my words. We are halting the progress of the disease to reduce the complications. So which level of the prevention is this one? Halting the progress of the disease. Disease have been already happened, so we are not allowing that particular disease to convert into the complication. We are halting the progress of the disease by the early diagnosis and the prompt treatment. Which level of the prevention? Secondary level of the prevention. We are reducing the risk factors. Which level of the prevention? Reduction of the risk factors by the policy making, by the individual health education. Yes, that is the primordial level of the prevention. Okay, so the specifically we are protecting against some high risk factors, and we are taking the intervention before the onset of the disease. Which level of the prevention is that one? The intervention which is taken before the onset of the disease. That is the primary level of the prevention, is the intervention which we are taking before the onset of the disease. Very nice. Okay, so next one which we have, the patient have been lost its functional ability. We are restoring the functional ability of the patient. So what is this one? So we are performing the rehabilitation. So the restoring the structural and functional ability. So that is the tertiary level of the prevention. Very nice. Okay, so these are the very important points to be keep in our mind, and the example on that one will be the very high yield for the exam. Okay, and remember, so here we have the beautiful information to aspirants who are preparing for the Norcet 11 and 12. So that is the plan even, the basic to advanced plan, so which is having the high yield and high quality lectures, PDF notes, subject wise test series, and the daily live test series, best teachers and the mentors, guidance and support, everything that is you want for your success we have here in this particular A1 plan. That is the basic to advanced plan for the aspirants who is preparing for the Norcet 11 and 12, and the aspirants who prepare for the RRB nursing superintendent exam and the CRE senior nursing officer exam. So this is the one plan for everything. Complete this plan, give your complete dedication for this plan for the duration of the 6 months. Attend all the class, watch all the class, revise all the notes, and attend all the subject wise tests, daily live test after completion of the 60 to 70% of the syllabus. So no one can stop your selection from this one. Okay, so what are the things you are getting here? The detailed classes with notes in a PDF format to use in the app only, and daily live test series, subject wise, topic wise mock test you are going to get here. Okay, yes, so this is a very important information on this one. And as all of you know that, so we have running the 5 days a very important free test series for the Norcet exam with a timer, with a real-time practice, so which is there free of cost in the master nursing classes app for the duration of the 5 days. So you can join the free test and attend the free test and check your level of the preparation. Okay, so that will be a very much helpful, and that will give the configuration to you before going to the exam. That will give the complete clarity to you before going to the exam. How many questions are going right, how many are going wrong, and how many I need to attend. Everything it will be gives as a very complete clarity. So please do attend the mock test which is there in the free of cost in the master nursing classes app. So now you tell me the very important examples which is the examiner favorite, where the examiner will very frequently strike these questions. So the healthy food practices is which level of the prevention? So remember, healthy food practices means we are reducing the risk in the future. So that is the primordial prevention. Yoga, early exercises, policy making, and early behavioral modification. These all are the part of the primordial level of the prevention. So please do keep in your mind. These all the examples are the examiner favorite, especially exercise, policy making, and the healthy food practices. Okay, so we have the second one, that is the primary level of the prevention, the specific protection in this one, the vaccination, prophylactic antibiotic, and the wearing the seat belt and the helmet while going on the bike. So these are the specific protection we are taking against some risk factors. And the health promotion like health education. So these all are the part of the our primary level of prevention. So this is the part of the primary level of prevention. Okay, very important. Next, which we have this one, early detection and the proper treatment. Early detection by the screening test. Okay, so that is the pap smear test, mammography, the low dose X-ray of the breast self-examination to early detect the conditions. So this is the secondary level of the prevention. And the proper treatment. Here we are providing the chemotherapy and the therapeutic drug for the treatment and the preventing the complication of the disease or halting the progress of the disease. We are treating the disease properly by therapeutic drugs. But a therapeutic drug use is the secondary level of the prevention. And most importantly, prophylactic drug use is our primary level of the prevention. So please do keep in our mind. Okay. And next, which we have here is that is the rehabilitation. So here we are restoring the functional and structural thing which is already lost. So that is the rehabilitation. Prosthesis we are giving, the artificial heart wall we are providing here. So this comes under the tertiary level of the prevention. So please do keep in our mind. This is important for the exam. Okay. Yes, sir. The next very important thing is, according to the NACO guidelines, how many clinical stages are there in the HIV infection is the question. According to the National AIDS Control Organization guidelines, how many clinical stages are there in the HIV infection is the question. Yes, Fataфат do mention your answer. This is important for the exam. Okay. According to the NACO guidelines, how many clinical stages are there in the HIV infection? Yes, the 4 stages are there in the HIV infection. So please do remember, from here the question may strikes. Okay, which stage of the HIV we will call as the AIDS? Yes, option A first stage, option B second stage, option C is third stage, and option D is the end stage or the 4th stage of the HIV. Yes, so which stage we are considering as the AIDS? AIDS is the last stage of the HIV, so that is 4th stage. Okay, yes, the total 4 stages we have. Among the 4 stages, the 4th stage of the HIV we will call as the AIDS. Sir, what is the AIDS, sir? That is the acquired immunodeficiency syndrome, which is caused by the infection, the virus called as the human immunodeficiency virus. So the HIV is not a disease name. HIV is the virus name. So this is the human immunodeficiency virus. AIDS is the acquired immunodeficiency syndrome, is the last stage of the HIV infection. So that is the 4th stage. In that one, the entire immunity is very low and patient is frequently getting the opportunistic infections and many more things. So we are going to deal and discuss all the things and all the stages here very perfectly. Listen carefully. According to the NACO guidelines. So stage 1 of the NACO guidelines of the HIV infection. So the first stage is the asymptomatic stage. So there is no any major symptoms. Okay, so there is only mild disease symptoms will come, like a persistent generalized lymphadenopathy will be there. So this is the very important thing. And in the early stage or in the first stage, only generalized lymphadenopathy will be there. Okay, so next comes to the second stage, that is the mild symptoms will be there. Okay, so in the second stage, so there are the mild symptoms will be there. Okay, yes, so in the mild symptoms, there is in the moderate weight loss is there, that is less than 10%, but if the more than 10% weight loss is happening, that is the third stage, that is the advanced stage. Remember, the weight loss which is happening less than 10% is the mild symptoms, more than 10% weight loss is the advanced symptoms. The less than 10% of the weight loss is the second stage, more than 10% of the weight loss is the third stage. Getting the point? And the herpes zoster infection, recurrent oral ulcers by the candida, and seborrheic dermatosis and the fungal nail infections will happen in the second stage. And in the third stage, the chronic diarrhea, that is the very important. Chronic diarrhea, that is more than for the duration of the 1 month. That is the advanced stage of the HIV infection, that is the third stage. And very frequent oral candidiasis, pulmonary TB, prolonged fever will be there, and the severe bacterial infection happens due to the low immunity. Okay, so that is in the advanced symptoms. So that is in the third stage of the HIV. Okay, and when it comes to the fourth stage, so there is the severe symptoms or the AIDS stage, which we can say the acquired immunodeficiency syndrome. In this one, the HIV wasting syndrome will be there. The complete patient will be Kachak-Zik. What is the Kachak-Zik or the Kachak-Zik? What we can say? Only bones are visible. Entire muscle mass is lost. So we can say a HIV wasting syndrome or the Kachak-Zik patient. Kachak-Zik in the sense, you can see the completely lean, thin. Okay, push, he will fall down. Okay, so when the speed air will come, he will fall down. So that kind of the complete body weight will be going to loss, and the only bones are visible, completely burn out of the muscles, and muscles are very thin. Okay, so that is what we call the Kachak-Zik patient or HIV wasting syndrome. And remember, the most common cause of the pneumonia in the HIV patient, that is the pneumocystic pneumonia or the pneumocystic girovici is the, or the pneumocystic Carni is the answer. So pneumocystic pneumonia or the pneumocystic Carni is the most common cause of the pneumonia in the HIV. And the Kaposi sarcoma is also will be seen here due to the human herpes virus number 8. Kaposi sarcoma, the most associated and the strongly associated cancer with the HIV. Kaposi sarcoma, the very important and very frequently asked question. Kaposi sarcoma in HIV. So please do remember, important, the most strongly associated opportunistic cancer in the HIV, the Kaposi sarcoma, which is caused by the human herpes virus number 8. And we have the esophageal candidiasis, but oral esophagus is there in the second and third stage. Oral candidiasis is there in the second and third stage, but the candidiasis is exposed to the Candida albicans infecting the esophagus also. That is in the 8th stage, that is in the 4th stage. And extrapulmonary TB, cytomegalovirus, which is causing the retinitis. Okay, and the cryptococcal meningitis will happen here, and the toxoplasmosis also may happen here. So please do remember these things. That is very important. And now we are going to see the next question. So this is very important for the exam. And after this question, the very high yield and very important golden points I am going to revise for you all. So listen carefully that one. Okay, so what drug is given to a HIV exposed infant for a prophylaxis under the NACO guidelines? Under the National AIDS Control Organization guidelines. So the infants you consider, or you can write here as the newborn. Okay, so you can write here as the newborn who exposed to the HIV positive mother. Okay, so what drug is given to the HIV exposed newborn for the prophylaxis under the NACO guidelines? So we have the option A, tenofovir, and judovidin, nevirapine, and efavirenz. So what is your answer? Yes. So how many of you will go with the judovidin? How many of you want to go with the judovidin? And how many of you want to go with the nevirapine? So completely text the name of the drug, judovidin or the nevirapine. So only two options you have here. I know efavirenz you eliminated and the tenofovir you eliminated. So please do remember, the single best answer always as a prophylactic which we are using in the a baby or the neonate which exposed to the HIV or the newborn born to the HIV positive mother, that is the nevirapine is the always first best answer. Okay, yes, measure what is there for the nevirapine, and the nevirapine is the first best answer here. Okay, so please do keep in your mind, and remember this very important thing, how we are going to prevent the mother to child transmission of the HIV. So the prevention of the mother to child transmission of the HIV. So this is very important. First and foremost to understand when there is the high risk of the transmission is there from the baby, sorry, from the mother to the baby. So from the mother to the baby, the high risk of the transmission is there in the which time? So during the pregnancy, during the labor, or after the pregnancy, that is in the postnatal period. That is antenatal, intranatal, or the postnatal. At what time the baby may get exposed to the HIV infection from the mother? So high risk is there during the labor or during the intranatal period. Okay, so that is during the intranatal period. So please do keep in our mind. Okay, so during the process of the labor, when the baby is coming out of the uterine cavity, so that time only the high risk of the transmission of the HIV from the mother to the baby will happen. So this is the very important golden point. Okay, and baby is exposed to the HIV positive mother means what we are going to do now here. Okay, so listen carefully. Now baby is exposed to the HIV positive mother. Okay, so mother's HIV status is positive and the newborn is born to her. So what we are going to, how we are going to take care of that baby? So listen carefully. So first and foremost, what we are going to do, so we are going to assess the risk of the transmission. So whether the baby, like mother infection, is transmitted to the baby or not. So that is, we are going to check the risk of the transmission. Sir, how we are going to check, sir? How to check, sir? Yes, we are going to check the viral load in the mother. Okay, so we will do the viral load test and we will see what is the viral load of the mother. If mother is having the heavy and more virus, that is the more than 1000 copies of the virus is there for 1 ml of the blood. In 1 ml of the blood, more than 1000 copies of the virus are there. So viral load is more. So it is considered as the high risk, which is considered as the high risk. Okay, so this is considered as the high risk. Okay, if in case the less than 1000 copies is there for 1 ml of the blood, so this is considered as the low risk. This is considered as the low risk. Okay, so if the baby, like mother, what you can say, viral load is less, means less than 1000, so that is called as the low risk. So here only give the nevirapine for the duration of the 6 weeks. Okay, so only what we are going to give, we are going to give the nevirapine for the duration of the 6 weeks. If in case high risk means more than 1000 copies of the viral load is there for the 1 ml of the blood, so that is considered as the high risk of the transmission from the mother to the baby. So in this particular time, so that is based on the whether the baby is taking the breast milk or whether the baby is replaced by the replacement feed. So based on this one, we are going to give the medication. So HIV positive mother, okay, so the high risk is there. In this one, the mother is giving a feed, the exclusive breastfeeding is going. That time judovidin plus nevirapine both we are going to give for the duration of the 12 week. For the duration of the 12 week, both judovidin plus nevirapine. Okay, so high risk mother, that is more than 1000 copies of the viral load is there for the 1 ml of the blood. So exclusive breastfeeding we are continuing. That time our treatment regimen would be judovidin plus nevirapine both, that is for the duration of the 12 week. And like the baby is not taking the breast milk, the replacement feed is there, external feed is there. So here also we are going to provide judovidin plus nevirapine both only for the duration of the 6 week. Sir, why both, sir? Why both means here the high risk is there. So with the breastfeeding you are giving 12 week, with the replacement feeding we are giving only for the 6 week. But we are going to give the 2 drugs in the high risk, that is the JAD and N. JAD, the judovidin and the nevirapine. So that's very important for your exam. So please do keep in your mind. Okay, so next is this one. Now consider the mother is positive for the HIV. And what about the breastfeeding? Whether we have to continue the breastfeeding or we should not, we should stop the breastfeeding. But HIV positive is not a contraindication of the breastfeeding. We can give the breastfeeding in the HIV positive. Okay, so mother is HIV positive means, so we can give the breastfeeding, there is no problem. Okay, so breastfeeding we have to give. So that is after breastfeeding, what we have to do after the 6 week, we are going to check the HIV status of the child. So after how many weeks? After 6 weeks, we are going to check the HIV status of the child. If in case, so now child is also having the positive for HIV. HIV is positive in the child. So breastfeeding we are going to continue for the 2 years. 6 month exclusive breastfeeding. After the 6 month, the complementary feeding plus breastfeeding both continued for the duration of the 2 years. Anyhow, the child is positive for the HIV. If we are stopping the breast milk also, again the immunity of the child is going to be low, so baby is going to die early. So we don't want the baby to die early. So that is the reason we are giving the breastfeeding, so that is at least it will give the immunity to the baby. Okay. In case after the 6 week HIV status is negative in the child means, so just we will give the breastfeeding, that is for the duration of the 1 year, not for the duration of the 2 years. Okay. So this is a very important thing to be keep in our mind, right? Is that clear to every one of you? What do mention? Is that clear? Yes, sir. What about the vaccine in the HIV positive child, sir? What about the vaccine in the HIV positive child? Remember, all vaccines are given to the child as per the schedule. But sir, live vaccines are contraindicated. When, sir? When means if the CD4 count is less than 200 and the relative CD4 count is less than 15% of the total count and the HIV symptoms are positive. When the symptoms are positive or the relative CD4 count is less than 15% and the CD4 count total is less than 200, that time the live vaccines are contraindicated. That time the live vaccines are contraindicated. So please do remember, if CD4 count more than like 200, so there is no problem, we can give all the vaccines, live and killed, everything we can give. Only criteria, in this situation we will not give the live vaccine. So please do remember. Okay. Yes, sir. The next very important thing, HIV and TB co-infection. So I keep on telling one word, very important word, that is for all the HIV patient we have to screen for the TB, and for all the TB patients we have to screen for the HIV. Okay. So this is very important here. For all the HIV patients we will screen for the TB, and all the TB patients we will screen for the HIV. If TB and HIV both are positive, what to do? What to do, sir? In a patient, TB is also positive and HIV is also positive. Whether you are going to start the antiretroviral therapy first or anti-tubercular therapy first. So here in this particular situation, we have to start the anti-tubercular therapy first. ATT is going to be start. The ATT is going to be start first. Sir, after how many weeks I can start the ART, sir? So listen carefully. After starting the 2 weeks of the anti-tubercular therapy, so you are going to start the antiretroviral therapy. So this is very important, because if you give the 2 weeks of the anti-tubercular therapy, this is considered patient is not an infectious to others. Okay, so he can't spread the infection to others. Okay, so this is very important. Please do keep in your mind. If TB and HIV both are positive, first we have to start the anti-tubercular therapy. Then 2 weeks we will give the anti-tubercular therapy continuously. Then after that, we are going to start the antiretroviral therapy. That is the treatment of the HIV. Okay, and if in case TB meningitis is positive, so that time first start the anti-tubercular therapy and give the 4-week gap and start the ART. In a case of the TB meningitis, we will give the 4-week gap, because this anti-tubercular therapy we are going to give for the 4 week. Then after the 4 week, the patient is considered as the non-infectious to others. Okay, so this is the very severe form of the TB meningitis. That is then the inflammation of the meninges happening due to the tuberculosis infection. So here first to start the anti-tubercular therapy, give the 4-week gap and start the antiretroviral therapy. Okay, sir, why ART we are going to start at the last, sir? Sir, why we are not starting both together, sir? Because our antiretroviral therapies are like having the drug interaction between the ATT and ART. That is, in the anti-tubercular therapy we have the rifampicin. This rifampicin is an enzyme inducer, so it will reduce the effect of the ART. So ART is not that much useful if we are starting together. So that is the reason, start the ATT first, then go for the ART. So this is very, very important. TB meningitis, first to start the ATT, then give the 4-week gap and give the ART. So this is very, very important. Next, as per the new NACO target, their aspirants, previously we used to have the targets of the 90%, 90%, 90%, 90%. So now 90 we have achieved already. So we have the next target in front of us, that is the target of the National AIDS Control Organization. That is, start the antiretroviral therapy irrespective of the CD4 count is the first statement. Please do remember. So if the CD4 count is 300, I will not start. After less than 200 only I will start. No, it is not like that. Whenever the patient will come positive, don't look for the CD4 count. Immediately start the antiretroviral therapy. Start the antiretroviral therapy irrespective of the CD4 count. Don't wait for the CD4 count to go less than 200. Start immediately antiretroviral therapy. Okay. So among this particular antiretroviral therapy treatment, so we have to be follow 95, 95, 95, 95 percentage. What it means? So whenever you will diagnose a patient with HIV, so among those 95 percentage cases should be confirmed. Okay, it should be diagnosis should be confirmed first. So after this 95 percentage of the cases which we confirmed, then after that we are going to provide the best treatment for the 95, at least 95 percentage of the patient who diagnosed with the HIV should take a best treatment. So among these 95, at least 95 should be shows the viral load suppression. And among these 95, at least 95 percentage of the people should be living with a good health and quality of the life. So this is 95 percentage people should be properly diagnosed. Among these 95, the next 95 percentage of the patient should be properly treated. Among these 95, the next 95 percentage of the patients are shown with a viral load suppression. Among this 95, the again 95 percentage patient who is taking the good treatment, so they should be live with a good quality of the life. So this is on the a very important thing you are going to follow here. Okay. So next is the old guidelines which we have here. So that is the 90 percentage. Okay. So this is very important to be keep in our mind. Okay. The screening and diagnosis of the HIV. Okay. So this is very important for the exam. We are going to keep in our mind about the screening of the HIV and the diagnosis of the HIV. So please do remember, now we are not following 90 targets. So now in front of us, according to the latest NACO guidelines, we have this target, that is the 95, 95, 95, 95. Okay. So I hope it is very much clear, right? Yes. So the next very important thing that you should keep in our mind, that is the screening and diagnosis of the HIV patient. Sir, where we are going to screen this patient, sir? This one should be screened at the ICTC center. So what is the ICTC, sir? ICTC is the Integrated Counseling and Testing Centers. Okay, so remember. So this is in the Integrated Counseling and Testing Center. So this is very important. In all the AIMS hospitals and in all the ESSC, everywhere you are working at the central institutes. So everywhere we have the ICTC center. Okay, sir, what we are going to do in the ICTC centers? Here we are going to counsel the patients and we are going to test the patient and we are going to guide the treatment also. So that is screening and diagnosis, especially by the testing, to be done in the ICTC center. Remember, okay, sir, what are the tests which shall be done in the ICTC center? The three very important tests, that is the ERS. So that is the ERS are the three very important tests we are going to perform in the ICTC center. The first one is the ELISA, second one is the rapid test, and the third one is the spot test. Okay, so the ELISA, rapid test, and the spot test. So these are the three very important what we can say test we are going to perform at the ICTC centers. Okay, so first test and the best test, most sensitive test of the HIV is the ELISA. So this is the examiner favorite question. So please do remember, examiner favorite question. So that is the best test, most sensitive test, and the first test we are going to perform in the HIV positive patients. So that is the ELISA, most sensitive, first test, that is the ELISA. So please do remember this one. This is important. Okay, so whether we are going to perform only ELISA or all three, sir. So please do remember, in the ICTC center, when the patient will comes, we are going to perform all these three tests: rapid also, spot also, ELISA also. Okay, so among these three, which is the best, which is the most sensitive, which is the first? So that is the ELISA is the first, ELISA is the most sensitive, and ELISA is the best we are going to perform here. And other than this one, these questions also will be struck in your exam as the maximum question. What is the confirmatory test for the HIV patient? Remember, the confirmatory test for HIV is the Western blot test. So please do remember in your exam. Sir, what we are going to do in the Western blot test? Sir? In the Western blot test, we are going to identify the specific antibody against the HIV virus. HIV virus is the antigen. Against this antigen of the HIV, we are identifying the specific antibody. So against the HIV, we have the specific antibody that is positive. It means compulsory HIV is there in the blood. So it means there is a HIV infection is confirmed. So that is by the Western blot test. What we are checking in the Western blot test? Specific antibody detecting against the HIV virus. So that is the very important thing to be keep in our mind. Next is the gold standard test. The gold standard test which we are performing in the HIV patient, that is the HIV RNA. Remember, the confirmatory is the Western blot. Gold standard is the HIV RNA. So this is important. And from this particular today's class, you will get the many question in the tomorrow's test. I don't want any one of you to make wrong in that one. So please do make all the questions correct what I am teaching today to every one of you here. Okay. So gold standard test for the HIV is the HIV RNA, and confirmatory test for the HIV is the Western blot, and the most sensitive and the first test to be performed is the ELISA. Getting the point? Enzyme linked immunosorbent assay is the full form of the ELISA. Examiner will ask the full form. What is the full form of the ELISA? That is the enzyme linked immunosorbent assay. One more time I will repeat. Enzyme linked immunosorbent assay is the full form of the ELISA. So the full form of the ELISA they may also ask in your exam. So that is the first test and the most sensitive test of the HIV. Confirmatory is Western blot. Gold standard is the HIV RNA. Okay. So test we are assessing to check the progress of the HIV. So the treatment we are giving the antiretroviral therapy, that is the ART we are giving against the retrovirus, against the HIV virus, the treatment which we are giving. So that particular treatment is working or not. What is the progress of the disease? So you want to check. What is the test you are going to perform? Remember, to assess the prognosis of the HIV, so CD4 count is the best test. CD4 count you are seeing. So CD4 count are improving means the disease is getting like little bit improving. The CD4 count is coming down means it is worst prognosis. Okay. So the test which we are performing to check the effectiveness of the HIV. So this is the another question. Okay. So to check the prognosis of the HIV, CD4 count is the best, and the test to check the effectiveness of the HIV. ART. So antiretroviral therapy you are giving, so that is effective or not. That time we are going to check the viral load by the P24 antigen assay. If the viral load is less, means ART is working good. If viral load is more, means antiretroviral therapy is working less. Very simple. If you want to check the effectiveness of the antiretroviral therapy, check the viral load. How you are going to check the viral load? So that is by the P24 antigen assay test. This is in the early test to get positive, and this is also you are going to remember. Okay. So in HIV, which test is early to get positive? That is the P24 antigen assay is the earliest test to get positive, and to check the effectiveness, viral load you have to monitor. That is the by the P24 antigen assay. So this is a very important. We are going to keep in our mind, and these questions will strike in our exam. The next very important point is most common type of the HIV in India. So which HIV is most common in the India? So the most common type of the HIV in India is the HIV number 1. HIV number 1. Sir, we have the two types of HIV. So HIV number 2 and HIV number 1. So that is the HIV type 1 and the type 2. So among the type 1 and type 2 in India, the type 1 is most common. Sir, in the type 1 we have the subgroups. Type 1 is having the 4 groups. That is the type 1M, type 1N, type 1O, type 1P. So that is the M, N, O, P. So these are the groups which is there in the HIV 1. And the subgroups of this particular very important groups are, so like in the M we have the A type, B type, C type, D type, E type and F type. So now you tell me, among these which is the most common? Sir, whether the M or N or O or P. So among the group, M is most common. And among the subgroup, which is the most common, sir? Among the subgroup, the C is most common. So how you will write the most common? You will write the most common like this. Okay, most common. Right? Here the M is most common and here the C is most common. This is how you are going to remember. Okay. So M is most common in a group, and in the subgroup, C type of the HIV1 is most common. So overall, which type of the HIV is most common in India? HIV type number 1. In this one, the group is M group and the subgroup is C. So HIV1 M C is the most common type of the HIV in the India. So please do keep in your mind, and from here you may expect a question. Sir, you told we have the HIV1 and HIV2. So what is the difference between these ones? Let's learn the difference. So types of the HIV which we have is the type 1 HIV and type 2 HIV. So this type 1 HIV is the most common HIV in India. Just give me a second. Just give me a second, please. Okay. So HIV1 and HIV2 we have. In this one, the most common type of the HIV which we have is that is now India most common one is that is in India HIV1 is most common. Okay, and HIV2 is less common in the India. And most virulent, most dangerous in India is the HIV1, and the less dangerous overall less virulent and the less dangerous is the HIV2. And HIV2 is not most common in the India, and which will be detected very less. Okay, and the HIV1 is seen in all the countries mainly. Okay, but HIV2 is mainly seen in the African countries. Okay, and HIV1 will takes to convert from HIV stage 1 to the advanced stage of the HIV. So HIV1 to the advanced stage of the HIV, the time taken will be, that is by the 10 to 15 years in the HIV1. Okay, so in the HIV2, the time taken will be, so that is some technical issues. So just give me a second. Okay. So I told HIV1 is most common in India, and this is most virulent, and this is seen in the almost all countries, and it takes the 10 to 15 years to show symptoms. And stage 1 of the HIV may get converted into the advanced stage of the AIDS, so that is taking the time of the 10 to 15 years. But HIV2 takes the 15 to 20 years, and this is less virulent, so that is the reason it taking the more time to show the symptoms. Okay, so mainly this is seen in the African countries, and this is all over the world, and India is also most common is the HIV1 we have. Okay, so next which we have is, so that is a window period. So what is the window period? Window period in the HIV is the very simple. This is the a time of the onset of the infection to the detection of the first antibody in the blood against the HIV is the a window period. Okay, so what is the mean of the window period? So infection is happened to the patient, and how much time is required to show the antibody against this particular infection is the window period. Okay, so what is the window period? The window period is the time gap between the onset of the infection to the detection of the first antibody in the blood against the HIV. So in this particular time gap, so we can say there is no antibody, right? So there is no antibody means the virus are growing very rapidly and virus are very infectious. So the question is, if what is the highly infective period of the HIV means the window period is the highly infective period of the HIV. So that is the like 2 to 12 weeks around it takes as the window period. So why it is highly infective means, so here the infection is happened, but here we don't have any immunity against that infection. So this particular virus is growing very rapidly. So this is high viral load without antibody in this particular gap. So that is the reason the window period is the highly infective period of the HIV. So this is the point you are going to keep in your mind. So I hope this particular concept is very much clear. Okay. So next you come to this very important points. What is the normal CD4 count? What is the normal CD4 count? Normal CD4 count is 800 to the 1200 cells per microliter. This is the normal CD4 counts, important for the exam. So please do keep in your mind. Sir, to diagnose the AIDS, what is the level of the CD4 count? So that is less than 200 cells are there for the microliter. So if the CD4 count is less than 200 per microliter, so this is called as the case of the AIDS. Okay, so normal CD4 count is 800 to 1200 cells per microliter, and when we will say AIDS, when the CD4 count is less than 200 cells. Main cells which is targeted by the HIV virus is the CD4 cells. Okay, so that is the cluster differentiating type for cells. Okay, so that is very important. And these are the golden points. Most common type of the pneumonia in HIV positive patient. Most common cause of the pneumonia. Most common cause of pneumonia in HIV positive patient. So that is already I have told. In HIV positive patient, most common cause of the pneumonia is the pneumocystic gyrovc or the pneumocystic kernel is the most common cause of the pneumonia in HIV positive patient. Okay, and what is the most common cause of the diarrhea in HIV positive patient? The most common cause of the diarrhea in HIV positive patient means cryptosporidium is the most common cause of the diarrhea in the HIV positive patient. So please do remember. Okay, so this is important for the exam. Cryptosporidium, most common cause of the diarrhea in HIV positive patient is the cryptosporidium, and most common cause of the pneumonia in HIV positive patient is the pneumocystic gyrovc and pneumocystic kernel. Important golden points, right? The next very important cause of the Kaposi sarcoma, already we have told, the most strongest associated cancer with the HIV positive patient, so that is the Kaposi sarcoma. So the most common cause of the Kaposi sarcoma is the human herpes virus number 8. What is the cause of the retinitis in HIV positive patient? The asked question, that is the cytomegalovirus. Cytomegalovirus is the most common cause of the retinitis in the HIV positive patient. So please do remember. Cause of this sarcoma, Kaposi sarcoma is human herpes virus number 8, and the cause of the retinitis in HIV positive patient is the cytomegalovirus. So this is important. Please do keep in your mind. From here you may get the question. Next comes to the heart therapy. The full form of the heart asked in the Norcet exam. Sir, what is the heart, sir? This is the highly active antiretroviral therapy. So that is called as the heart therapy. Sir, what is the heart therapy? Heart therapy is the highly active antiretroviral therapy is the heart therapy. So this is we are going to keep in our mind. And in this one we have the tenofovir, lamivudine, dolutegravir. Okay, so these three are the drugs, the fixed dose combination drugs. Okay, so there is the tenofovir, lamivudine, and the dolutegravir are the drugs which is part of the heart therapy. So this is one tablet which we are giving for the 28 days in a patient who exposed to the HIV positive. Okay, so that is called as the post exposure also. Okay, so you can see here the HIV post exposure prophylaxis as per the NACO guidelines, as per the National AIDS Control Organization guidelines. Sir, when to start this one? Very important. When to start the post exposure prophylaxis? Start as early as possible is the first best answer, and preferably within 2 hours is the best. Okay, so this is a best. Sir, what is the maximum time limit which we have, sir? You can start up to 72 hours. Okay, you can start up to 72 hours. After 72 hours, sir, the post exposure prophylaxis is not recommended and it is not useful also. Okay, so maximum time you can take is up to 72 hours and best you can give within 2 hours. So that is the HIV post exposure prophylaxis NACO guidelines. And duration of the post exposure prophylaxis is the 28 days. That's the 4-week duration which we have. Very important. This one must and should be complete mandatory. Okay, so preferred regimen. So already I have told the triple drug therapy we have. So that's the fixed dose combination for the adults and adolescents. That is the triple drug regimen. Remember, tenofovir we have, that is the TDF also we can call, and the lamivudine we have, that is the 3TC we can say, and the dolutegravir we have, so that is the DGT also we can see. Dose will be 350 mg. Okay, tenofovir 300 mg, lamivudine 300 mg, dolutegravir 50 mg. All will becomes in a one tablet. That is the fixed dose combination. So once daily we are going to give this one. Okay, so please do keep in our mind, this is taken for the duration of the 28 days. This is the post exposure prophylaxis of the HIV. So I hope every question, every point on the HIV and the new guidelines of the our ANTRA or the DMPA, so that is very much clear, the subcutaneous DMPA and the National TB Elimination Program guide updates, the guidelines and the WHO new TB treatment guidelines. I hope it is very much clear, and the thing is, the way is very clear to choose the correct answer, and many more things we have discussed, that is the very basic to very advanced in this particular today's class. So this class is going to be a very important class for your exams. So please do revise the notes from the A1 plan or from the A2 plan. This is going to be definitely beneficial in the exam. Quickly revise the notes and finish it. Okay, so thank you so much for watching the video till here. Bye bye, take care. We will meet again with the most and the more important updates in the future. So if any one of you are still not a part of our Telegram group and WhatsApp group, so the link is there in the description box. You can join there. So all the class timings and updates, everything you are going to get from there. And most importantly, I told all India level, the champions who all are having the clarity of the concept is going to compete with you in the free test, which is conducting in the Master Nursing Classes app. So please do download the app and give the free test to check the level of the preparation. So all the best for your upcoming prelims exam. So we will meet again in the tomorrow session. So please do share this class also with your friends. Thank you so much to every one of you. We will meet again. I hope that today's session you enjoyed a lot. Okay, yes, so best wishes. Bye bye.